Thank you for joining us for Conversations in High-Risk Non-Muscle Invasive Bladder Cancer. During this segment, we'll be discussing the current treatment and management of non-muscle invasive bladder cancer. I'm Josh Meeks. I'm an associate professor of urology at Northwestern University. And today I'm joined by my colleagues, Dr. Matthew Galsky and Dr. Abhishek Tripathi. So I think a good place for us to kind of begin is where bladder cancer fits overall. We know it's the fourth most common cancer in men, somewhere between 6th and 9th overall. And I think, since we're talking about non-muscle invasive disease, I think one thing that people are relatively surprised about is how common non-muscle invasive disease. I mean, overall, we think about 4 out of 5 cases are, early stage or non-muscle invasive disease. And really, what I hear when patients come in are, anything from they think they're going to die from this to this is nothing and they don't really have cancer. I guess my first question to you folks are, when you see people with bladder cancer, especially early stage, how common are they coming to see you from a medical oncology perspective for a second opinion? I tend to see that there's a little bit of variety in the patients that seek out a medical oncology opinion. Are you seeing more early stage patients now than before, or is that pretty common that you see folks?
So I'd say that for non-muscle invasive disease, I think we're seeing a little bit more in the way of patients with BCG unresponsive disease over the past few years, but there's always a small cohort of self-referred patients with non-muscle invasive disease who, just want to see an oncologist. I tend to hear that. Honestly, sometimes people in academic centers where medical oncologists, focus on specific types of cancer, sometimes people are a little bit surprised that I'm not a urologist and that I'm not going to do their scope.
What about you, Abhishek? Do you find things? I mean, I think that patients seek you out, and sometimes they think that I'm going to give them chemo. So I kind of see the opposite side of this, but I think it's good that they hear probably very similar things from you as a medical oncologist, that the surgeon is not doing something that's, being driven by surgical things, even though what I tend to find is that the majority of early stage bladder cancer is very surgical. It's a lot of endoscopy. It's a lot of intravesical therapy. I know more and more we're working together as a team in early stage, but I think that patients benefit when they see a medical oncologist. So how do you tend to form those discussions with patients?
Yeah, completely agree with Matt's comments earlier. So we are at a crossroads of intersection between where surgical care and systemic care and the intravesical care kind of meet. So as Matt mentioned, most of the patients that I see tend to be muscle invasive or higher stage, but we do have several self-referred patients who are looking for a non-intravesical option, or perhaps they have already exhausted the intravesical therapies and are seeking out an option or an alternative to cystectomy specifically. So we do tend to see those patients, not very commonly, but it's getting more common as more and more treatment agents enter the non-muscle invasive space. That provides us an opportunity to actually collaborate with our urologist better and have a uniform plan when that happens.
And I'd say it's a paradigm that we're not totally unfamiliar with. I mean, treatment of localized prostate cancer, of course, the medical oncologist's role in those actual treatments is oftentimes limited, but we'll see a decent number of consults for individuals with localized prostate cancer who just want to hear from someone else what to do.
Absolutely. And I think another pair of ears and another pair of eyes just to kind of see and talk through things, sometimes other concerns that they may not be able to voice to urology teams. I think it just helps some of the patients cope with it.
It's a good point that multidisciplinary clinic, which is already developed for prostate cancer, probably, and we may utilize more in muscle invasive disease. I think, moving into some of the higher risk patients earlier probably makes a lot of sense. I think one thing that I've been interested in is, you both treat patients at some point probably with lung cancer, and we know that the prevalence of lung cancer is potentially going down, that the mortality is improving. Are we seeing the same strides overall in bladder cancer? Because I think the epidemiology data would suggest that our survival hasn't improved, whereas it has for lung. Do you sense that clinically, or Do you have any ideas of why that may be the case?
I think they're a little bit, they're a few years ahead of us in lung, right? So lung cancer screening certainly has had an impact despite some of the difficulties with any screening modality in terms of establishing that it saves lives. I think there's definitely been a stage migration, and arguably there's improved outcomes in lung cancer with screening. So I think there's that. There's targeting oncogenic kinases in lung cancer, which of course has had a huge impact, and that's probably 10 years ahead to 15 years ahead of where we are with systemic therapies in bladder cancer. So I think it's coming. I mean, this is certainly anecdotal, but I see that my patients with advanced disease are living longer. I think it's hard to question that. We just don't see it in the data yet.
So interested in sort of your thoughts on our risk stratification. I think, as a surgeon, I feel largely responsible for putting because for the most part, it's a clinical stage that we give patients in the beginning, right? So most people who we take care of with early stage bladder cancer, their imaging is going to be normal. I'm usually getting one scan, or the patient already comes with a scan. And then when we get to basically risk stratification, that's assigned by us, both by exam and by TURBT. And I'm fascinated how most of it is based on pathology. You're all at tertiary centers. I think we try to get much of our pathology re-reviewed. I mean, I'd say that the pathology is what dictates most of that. How essential do you find that pathologic re-review to really make sure that we're calling a T1, that they're not a T2? How much discrepancies do you see in the risk stratification based on pathology?
I do think there is a significant need, I think, especially when we see patients and referrals from community sites, to have an experienced GU pathologist look at all of our cases. So that's our standard practice at our institution in City of Hope, that even non-muscle invasive or any new consults, we have pathologic confirmation. And this couldn't be more important for non-muscle invasive bladder cancer, because the treatment options are so different whether or not you have evidence of muscle invasion. So our practice is to counsel the patient that we will review and confirm the pathology. And if there is any discrepancies, perhaps a repeat biopsy or repeat cystoscopy is usually in order for that.
So, as a clinician and a clinical trialist, I find the non-muscle invasive bladder cancer space incredibly confusing. I think it's in part that I don't live this on a day-to-day basis, but, talk about a field where there's multiple different definitions and risk stratification schemes in different countries, endorsed by different governing bodies, even within the same country. I think from just clinical trial sort of basics in terms of being able to define things and then study them consistently, I think, from an outsider sort of perspective, I think this is one of the things that has made studying non-muscle invasive bladder cancer very challenging over the years. And, to the credit of you and your colleagues, I think just recently all that's been starting to rein in. Probably just in the past, 5 to 10 years.
It's a huge point. And I think part of it is just trying to have consistent terminology, right? And the goals are different, right? I mean, I'd say the AUA guideline from 2016 tries to pretty cleanly put patients in low risk, intermediate, and high risk buckets. And there's different goals there, right? So for low risk, it's kind of less is more. We're trying to not over-cysto them, over-treat them, save therapy because they don't really need it. The intermediate risk group, they're going to experience recurrences, and how do we treat that? I think they've become a new high interest group. These are recurrent low-grade cancers. And so there's a lot of therapies coming down the road for them, because these are patients who are very close to being, really normal and not having recurrence, but they just keep having these low grades. So there's a lot of therapies coming for them. And then the high-risk patients, you're dealing with recurrence, and the big concern is progression. There's 3 to 8% that will have metastatic disease, and that's such a low likelihood event, but it happens, right? Each of us have a patient with a normal bladder that's going to have metastasis every year. And so those patients shape your practice. So how do you not over treat everybody, do cystectomies, give way too much care for this very low risk event? So I think that's really the challenge, that every one of them is different, but at the same time, like, we have to kind of manage them. I still think, we're stuck in this world where BCG is king. I can go on and on about how we think BCG is a terrible drug, but at the same time, a very good drug that, when given right, our contemporary outcomes are 70-80% recurrence-free survival at 2 years. It's hard to beat that. I think, my biggest question for you guys thinking about clinical trials, and I know you're really actively involved in, is how do we do a better job than that? Like, again, when you look at a response rate of almost 80%, how do you improve that?
Yeah, I think it's not easy, and that's why it's been king for so long. It's a fascinating story in and of itself, and I also find it fascinating and sort of thrilling that some of the folks who were involved in shaping that treatment are still, around lecturing, and it's pretty amazing. That we all, as clinical trialists, we all try things and we hope that they're going to work, and most of the things that we try, unfortunately, don't work. And can you imagine, this concept was a little bit off the wall, and just putting this into people's bladders, and it changed the way that we treat patients throughout the world for decades to come. It's an amazing story. All of that said, to answer your question, I think, improving upon something that works well is always difficult, but I think we have to define then what it means to work well. And response proportions and response durations are of course, two different metrics. And I think we're running into that same problem in first-line treatment of metastatic urothelial cancer. It's like a problem that we never thought that we'd have. But we have regimens that have response rates now in the 60 to 70% range, and it's hard to expect that response rates are going to improve dramatically beyond that with sort of some of the minor tools that we have now. But we can definitely try and improve response durations and try and make it so that less patients develop recurrence. And I think that it's probably going to be about shifting metrics, and unfortunately, that means larger and longer studies.
Abhishek, can I ask you, we have, I think, at least 3,000 patient trials where we're taking BCG and adding a checkpoint to it. And I think the hope is that it's a little bit better, but when I counsel patients about toxicity of BCG, that's all related to frequency, urgency, flu-like symptoms. Your counseling for checkpoint therapy is very different in a metastatic patient. How do you see these fitting in? Do you think, obviously we have them, and there's certain patients we can talk about that get it for BCG unresponsive disease, but how do you think it'll fit into the BCG naive setting, and how do you balance the risks for patients?
Absolutely. I think that's an important question that we're trying to deal with. So I think my discussion for the most part has been as part of the participation with clinical trials in the BCG refractory setting, where we have co-managed the patients with urologic oncologists at our centers. And I would talk to the patient, and the important thing to remember in this setting is these patients have not had any form of systemic therapy or have never had the need to have any systemic therapy. So their expectations in terms of adverse events is also slightly different from our regular medical oncology patients. So it is important to help them understand the potential for systemic side effects, which can take a little bit of time for patients to get to grasp, and for us to be comfortable that it makes sense in a risk stratified patient population. I think to answer the question of whether the BCG naive population is going to be as effective and adopted, I think that remains to be seen. I think it's going to have to be able to make a significant impact on outcomes, because as you said, the response rates with BCG are quite high. So in BCG naive, when you add in the systemic toxicities for a patient, the uptake might be low, but I think if the impact is big enough, I think those are going to be driving the discussions. The good thing about immune checkpoint inhibitors is that across the board, they are generally well tolerated in the majority of patients. but there will be a small subset of patients that will have long-term life-altering consequences. For example, if somebody develops hypothyroidism or pneumonitis, those are hypothyroidism being a common one, that patient will have to have a lifelong thyroid replacement now that he didn't need before. And on the more severe end of things, pneumonitis and other more severe side effects. So it's important to be cognizant of these things and counsel patients appropriately. I think ultimately it will have to be a significant impact on outcomes and tolerability in combination with BCG that will drive the discussion.
Yeah, I totally agree with you. And I think one of the exciting thing about all these trials is they have an arm where checkpoint comes on and BCG comes off. So it could be as a replacement. Well, I want to thank you all again for joining us for this segment on the current treatment and management of non-muscle invasive bladder cancer. Be sure to click on the landing page for this activity to claim your AMA, ANCC, ACPE credit, access supplemental slides, as well as other topic segments and case scenarios.